Welcome, Dr. Ashok Seth, sir, also
Thank you.
just joined. We wanted to have, with your permission, sir, we wanted to have slightly different perspective, different opinion from you apart from the stents. If you permit us, we'd just like to ask, because we don't get to talk to you this off for the track type of discussion, which is apart from the stents. With your permission, what I would like to ask is, you are a great role model and inspiration for all of youngsters for clinical research, and you pioneered in making left mains coming into interventional cardiology era, and also domains of mitra, clip, and other things. Also, you made positive outcomes by planning the proper clinical trial, I feel. So, when did you get interest in this clinical trials? Was it right from your childhood levels, and how did you get into this?
No, I must say when I was a child, I wasn't that interested in randomized trials. I was more interested first in sports and then in girls. But that changed, I think, as I got deeper into medicine. And really, I would say the seminal event that showed me the importance of randomized trials was the caveat trial. And many of you may remember it, may not remember it. I'm sure Ashok remembers the caveat trial. We were very excited about going beyond balloon angioplasty, and the first new device angioplasty technique was directional coronary atherectomy, which was a very large catheter where we could excise the plaque, and we would get beautiful angiographic results. We'd rarely see dissections. Maybe the residual stenosis was 10%, but compared to balloon angioplasty, angiographically, it was just night and day difference. And we were 100% convinced that the long-term outcomes would be different. So Eric Topol was the principal investigator and led the caveat trial, which actually showed a higher rate of periprocedural myocardial infarctions with DCA compared to plain old balloon angioplasty, and no significant difference in restenosis. And that was a shocker to all of us. And it actually then, and Gary Mintz could speak to this, made us look into, well, why was this happening? And really, it was intravascular imaging that showed us the mechanisms that we weren't really being very effective with DCA. Not only was it a big, bulky device that could actually cause some harm, but we were actually not removing much of the plaque. And again, the angiogram looked fantastic, but angiogram is a terrible discriminator. And so we then were able to do optimal atherectomy type studies and show that we could get better outcomes, but it would require much more aggressive atherectomy, often image guidance, to prove that we were doing a better job. All of that then got supplanted by stents. And again, stents were also very important in the randomized trial era, especially then the FDA was starting to come on and believe that randomized trials were the only way to prove safety and effectiveness, and they wouldn't approve stents in the United States, other than a very short, very strict purpose to treat acute closure. And they insisted on the initial stress trial being done, and that really ushered in the stent era. And ever since then, pretty much, if you really want to understand the relative safety and effectiveness of devices, of pharmacotherapy, of different strategies, you really need randomized trials. That being said, randomized trials do have their limitations, and there's an important role for large observational registry experiences as well to look at clinical practice patterns, and of course to look at low frequency safety events and other outcomes that you can't see in even 2,000 or 3,000 patient randomized trials.
In fact,
That's great, Greg. I think.
Go ahead.
Sorry. Yeah, I was just going to say, I mean, it's an amazing perspective, and I think really important for trainees and people that are not familiar with that history to think about. I just wanted to ask you specifically, Greg, one thing, because I think especially abroad, everybody sees you on the podium and sees you moderating cases and that sort of thing. Can you talk a little bit about your early days recruiting patients and how that kind of has informed how you are today? Because that's a unique perspective that many people don't know. I don't think about you is that, when you were in practice and you were the only guy there and recruiting, maybe talk a little bit about that.
Well, thank you, Ajay. When we started doing clinical research in general, and I really got involved in clinical research as a cardiology fellow. Well, actually, I started even as a undergraduate student, but that was in basic science laboratories. But then as a first medical student, an intern resident, and then cardiology fellow. And for the most part, there weren't big organized research units back then. So we would go consent the patient ourselves, and we would sit there, 30, 45 minutes with each patient. It's describing the pros and cons of a research study and what they would expect from it. And I can tell you, when you do that as a physician, your recruitment rate will be 95%. I mean, if you've got trust with the patient and you really sit and spend the time, very few patients will ever object to being in a well-designed research study, which might be in their best interest. Of course, you can't promise that, but it might be. And most patients really want to help society as well, and that's a real big motivator for patients. But when you use a big system and research coordinators just flying in and saying, here's a study we want you to participate in, I think then you've got more about a 1 in 4 chance for the patients to sign up. So that's just one perspective. But the second perspective is that we didn't have funding for a lot of these research trials. So we would fill out our own case report forms. We often didn't have research nurses. And so, for example, the PAMI trial, which I was one of the co-principal investigators on, led by Cindy Grimes, that changed the world for primary angioplasty. We did that at 12 sites. The database was an Excel spreadsheet, and we had a 10-page paper case report form. And we would, fax the paper case report form to William Beaumont Hospital, and they would enter the data, into an Excel spreadsheet. We had one person outside the physicians that was involved in the STEM-PAMI trial. So it just really shows you what you can do when you're very, very motivated to address research. And there's no doubt that obviously our systems have gotten much better, and our quality control is much better, and we have more accuracies by monitoring patients and separate oversight, et cetera. But it has come with a cost and loss of the personal touch between the physician and the patient.
Thank you, sir. I think you mentioned to us the negative trial inspired you, and more you came into research. But what is the most positive trial which you were part of it and which excited you more and which gave you maximum happiness? Excel trial?
Oh gosh, I don't know. Fortunately, I've led about 130 different trials, and they're all like your children. And so I don't know that I can choose between one of them. But I will say, most recently, the COAP trial, again, of the MitraClip in patients with secondary MR and heart failure, was just such a pleasant surprise. It was such a difficult trial to complete, and then seeing the marked magnitude of benefit, it's really something that none of us had dared hope was going to be that positive. Given the fact that it was the right trial at the right time, because I think the field of mitral valve therapeutics really needed it. And so it was very gratifying to be involved in the COAP trial.
Thank you, sir. I would say yesterday, Dr. Martilian mentioned that there's a lot of scope for work in heart failure. And what is your future plan? What are your interests in future trials? What is your what do you feel where we should concentrate more?
Well, obviously, the coronary intervention has become, a very mature subspecialty. But as I said, I do really think that we can continue to improve outcomes with appropriate lesion selection, especially with intravascular imaging guidance as well. I think, new techniques such as QFR, angiographic fractional flow reserve assessment, even pre-cath lab lesion assessment for physiology is going to make a difference. We're running the Illumian 4 trial, a 3,500 patient randomized trial of OCT guidance versus angiography guidance, which I think will be very important. Lesion preparation strategies. Ajay and I are involved in leading the Eclipse trial, looking at atherectomy in severely calcified lesions as a routine approach, not just for non-dilatable, non-expandable lesions compared to standard angiographic guidance. And that trial is almost done enrolling. So there's still work to do on the coronary side. But number one, on the coronary side, I'm a total firm believer that to reduce cardiovascular death and myocardial infarction, we have to switch from physiology to the concept of vulnerable plaque. We and others have now shown that you can identify vulnerable plaque, particularly with invasive technologies, but also non-invasively. And we now have to do the therapies trials to prove that either with pharmacologic intensification or with local plaque passivation strategies that we can improve outcomes for patients. And then the second major thing I'll say is that, our field has shifted with an emphasis to structural intervention. And it's really exciting to see what's going on there. Obviously, TAVR is now, I would say, a clear established subspecialty, and now we're playing on the edges of looking at bicuspid outcomes and asymptomatic disease and moderate aortic stenosis, et cetera, et cetera. But mitral valve therapy, tricuspid valve therapies, left atrial appendage occlusion, I think is just really barely getting started, and you'll see more data on that later. We've got a lot of exciting technologies for heart failure, as you mentioned, whether it's interatrial shunts or partition devices, ventricular reconstruction, other types of therapies for heart failure, endovascular baroreceptor modulation, et cetera, and hypertension. Again, structural approaches to hypertension, and Ajay's led a lot of those trials on the renal denervation side. I think all of this is going to really change the way we treat patients with a variety of different systemic disorders, not just that are directly related to the cardiovascular system. And that's not even mentioning endovascular, which of course is continuing to improve outcomes, starting from intracerebral stroke interventions all the way down to the lower extremity.
Thank you, sir. I think George Dangar sir is waiting. We ask him to excuse us for 2 more minutes. Dr. Seth, sir, would you like to ask anything, Dr. Greg, on this perspective?
My comment to Greg is it's just been a privilege to know him for such a long time as a friend, but I've also admired him for all these years. And Greg, I'm going to ask you a very frank question. You've been responsible for all the pivotal trials, but we've also admired you for the way you convey your thoughts to all of us at every talk. It's even the most complex subjects and even the most complex trials are made so easily logical by you, simplified in a manner which is very convincing, and in a manner where even in the most debatable topics, we end up being convinced by you. So there's fluency and smoothness of conversation and talk, which you are so admirably convey to everyone. Did that come right from the beginning? Were you a smooth talker all the time? Did you train yourself to be a smooth talker?
He did say he was interested in the girls. Ashok, he said he was interested in the girls.
I was going to mention
from
that
the beginning.
Well, you give me too much credit, Ashok, but thank you for those kind words. And in terms of simplifying things, maybe it's just that I have a simple mind is all it is. No, look, it's, when I started out, I don't think I had at all that clarity of thought. And to be very honest, and frankly, it just came from a lot of work and a lot of repetition. It really, to me, I think it started from writing again and again and again. And I was not a particularly good writer at the beginning. And I was always a strong science major, but I was terrible in English and those sorts of communicative skills. So I think it just came and over time. And, I did learn that, it's great to have all these thoughts inside your head, but unless you test them, and then unless you can effectively communicate them, then you're never going to be able to have a major impact outside of your own sphere. And so I did spend a lot of time making my own slides. I always write my own manuscripts. Ajay will testify, even when I'm not the first author, I'll always spend 4 to 6 hours reading every word and working on every single word of revisions, et cetera. And I think that's, basically what led to that over time.
Thank you. That's extremely helpful to a lot of audience who's listening to you.
I think can I
just, Srinivas, can I say one thing? Just because I've observed Greg in this way, and it's a good lesson for the junior doctors, is that you do need a level of compulsiveness, just like in a case. And when you check the wire position, you check everything in the same way every single time. That's the same that when you observe Greg, how he has exactly as he said, when he edits a manuscript, when he prepares a talk, you might say it's the 800th talk. Why do I need to spend so much time doing it? And the reason is because if you don't do it for the 800th one, then certainly you're not going to do it for the 900th one. And then by that time you're obsolete. And it's that obsession with, trying to be perfect and to be compulsive about it that, in my opinion, really sets apart someone like Greg and then others like him as well.
Great.
Thank you. We wish we had more time, sir. But one last word of advice to younger colleagues.
Yeah, if I could just jump in.
Sir.
Greg has set the example for the rest of CRF. Greg's standard is CRF standard. Maybe we don't quite do it as well as he does, but that's, what Ajay described, is the CRF standard. And there's no reason why it can't be practiced by everybody.
Well, Gary, thank you. But now you're making me blush, because I do have to tell you, it's so totally true. I mean, I have been blessed by working with people like you and Ajay and Marty and Roxana and George and so many others. And I must say, being around so many other driven, bright people who have their own independent source of ideas has totally contributed to my growth, and it's continued to motivate me as well. But thank you for saying that.
Thank you, sir.